Good afternoon, everyone. My name is Simran Chaudhary, and on behalf of Voice of Healthcare, I welcome you all to the National Virtual TB Forum 2025, supported by Cepheid and Metropolis Healthcare. It is an honor to have such a distinguished speakers and audience of healthcare professionals joining us today to discuss an issue of critical global importance, tuberculosis, on World TB Day. TB continues to be a significant TB continues to be a significant public health challenge with today's session. And today's session titled Accelerating TB Diagnosis, Innovation and Impact and Implementation aims to shed light on the latest advancements, challenges, and the future direction in TB diagnostics. And to mark this event a great success, we have a distinguished set of panelists. Dr. Niranjan Patil, Associate Vice President and Scientific Business Head, Infectious Diseases, Metropolis Healthcare Ltd. Welcome to our show, sir. It's a pleasure to have you. Dr. Parul Vadgama, Professor and Head Respiratory Medicine, GMC Surat, and Chairperson, IMA Union STCI Program Committee, IMA. Welcome to our show, ma'am. It's a pleasure to have you with us.
Thank you.
Thank you, ma'am. Dr. Indranil Halder, Associate Professor and Head Department of Respiratory Medicine, College of Medicine and GNM Hospital. Welcome to our show, sir. It's a pleasure to have you with us.
Thank you. Thank you.
Thank you so much. Dr. Santosh Kumar, Professor and former Head Department of Tuberculosis and Chest Diseases, SN Medical College. Welcome to our show, sir. It's a pleasure to have you with us.
Thank you, Simran. Thank you.
Thank you, sir. Dr. Abhishek Goyal, Professor, Pulmonary and Critical Care Respiratory Medicine. Welcome to our show, Dr. Goyal.
Thank you, Ms. Simran. Thank you.
Thank you so much, sir. Now, it's a pleasure to welcome our session moderator, Dr. Swati Tripathi, Director, Clinical Solutions, Cepheid. Welcome to our show, ma'am.
Thank you. Thanks, Simran. And thanks a lot for setting such a good context about it. If I can take it over from here.
Definitely, ma'am. Now I would like to hand over to you. Thank you.
Thank you. And good evening, everyone. And thank you so much for joining this important session on accelerating TB diagnosis. But we'll not stop at only TB diagnosis. We'll also talk about treatment, TB patient management. Giving you a bit of context, the tuberculosis, it's an old disease. Old meaning even few thousand years old, wherein it's even recorded in ancient times, some sort of written kind of records, and in multiple geographies. But even if we take the modern era and post the finding of MTB bacilli by Dr. Robert Koch in 1882, it still continues to be one of the top infectious disease killer worldwide. And that is when it is actually preventable and treatable. Though the bacilli is hard to eradicate, but yes, adherence to the treatment and proper antibiotic courses that makes it curable. But still, it remains a serious public health challenge, and mainly in low and middle income countries. So let me give you some data from the NTP report, which was published last year in 2023 data. 2.4 million notifications, wherein 63,000 or a little more than 63,000 were DRTB cases. and around 3.3 lakh people lost their lives to this disease. So this reality, and also the fact that there is still a gap in, in the active cases versus the notification that's happening. It underscores the urgency of addressing TB with novel strategies, active case finding, and then those cases need to be linked to care quickly. This said, all is not bleak. India's TB program has shown really good success by adopting new diagnostic and treatment methods. They adopted it very early on. Rollout of rapid molecular diagnostics has improved early detection, particularly for DRTB. And also the integration of private healthcare providers, wherein the TB notification has to happen on Niksha portal, that has bolstered notification rate. And the recent drive that we have seen by Central TB Division on active case finding, that's likely to shorten the gap in missing cases versus notification. Uh, Today we have World TB Day, and Metropolis Healthcare and Cepheid, in partnership with Voice of Healthcare, are organizing this virtual program. This for raising awareness, and also discussing, latest advancement in TB diagnostics. And of course, this is basically to facilitate the discussions among key stakeholders. Uh, Last, I'll say that importance of rapid diagnostics and quick linkage to care cannot be overstated. And we have the apt subject in this regard, accelerating TB diagnosis, which leads to innovation, impact, and implementation. Could I actually request Dr. Niranjan Patil to share Metropolis Healthcare's commitment to fight TB, and then we will follow up with a discussion with our esteemed panelists.
Yeah, thank you so much. Thank you so much, ma'am, for setting up the context, and thank you so much, Cepheid, and everyone here who have gathered on occasion of the World TB Day to create awareness, and not only to create awareness but also to combat this important disease that we are dealing with currently. So, with that, may I share the screen?
Yes, sir.
Oh. Actually, I'm finding there's some difficulty I've encountered while sharing the screen. Can you someone help, please?
So the present icon is there.
Yeah, I've clicked it.
Yes, Dr. Niranjan, am I
Yeah.
audible to you?
Yes.
So you're audible to us. You can start your answer.
Simran, Dr. Niranjan has to share a presentation.
Yeah, I
Okay.
think I can do it. Yeah. Okay. Are the slides visible now?
Slides are not visible. In fact, just seeing you.
I think Niranjan, you start without slide.
I don't mind. However, the audience.
end, and from there you can start. Slide share. So you mute. Yes.
Other slides visible now? Yeah, thanks.
Yes,
Thank,
yes.
sorry and thank you so much, for bearing with me. I think there was some uploading challenge that was happening. So yeah. So I'll be just speaking very briefly. I'll go through it very very fast because we have a panel discussion later on. So just to tell you what is our current disease burden. I think speaker previous to me has already spoken about the disease burden, but just to give an estimate. Currently, there are nearly 195 cases per every lakh population, which is there as per the global TB report. And out of this, in India, there are nearly 28 lakh cases which are there. The reported TB cases in 2023 were 25.15. Now, just to tell you the burden. So, as we have seen, India contributes nearly 28% of the world TB cases, and in fact, India, along with other 5 countries, they contribute to the maximum TB burden. So, India contributes nearly 28%, whereas the Russian Federation contributes nearly 7.4, Indonesia 7.4, China 7.3, Philippines 7.2. But the good thing about the current scenario is that there has been a reduction in the MDR tuberculosis, and nearly by 20%. So something which is good. However, there is something which is bothering us is the percentage of TB cases in the previously treated cases. So if you can see in the previously treated cases, the percentage is nearly 13%, which is actually a big number. Now, in recent years, as I said, India has made a fairly good progress. So, as we can see, how much the government sector is contributing is nearly 85% for drug-sensitive tuberculosis, whereas the success rate from the private sector is up to 87%. However, having said and done, emergence of drug resistance still is a major threat to the global efforts to end tuberculosis. Now, what are the challenges? Current challenges: there are high rate of misdiagnosis, and there's a limited access to advanced diagnostic tools. What I mean by this is not everyone has the access. So those are the current challenges we are facing. Now, this was the same thing. I was speaking about how much incidence is there in the previously treated cases. As you can see, there's a good nearly up to 13%, very clearly evident from this survey that was done by the first of such survey which is performed in India. So another issue is with the INH monoresistance, which is basically a driver of drug-resistant tuberculosis, especially MDR tuberculosis. Now, what has happened? This is the latest 2024 guidelines or the recommendations which are there by the WHO, which are talking about a BPAL M regimen, and they're also talking about considering the CB-NAT-based assays, especially which also look at XDR diagnosis. So these are the current recommendations by the WHO and by the NTEP. So this is just to facilitate the the early initiation of the patients on treatment pending the phenotypic results. Now we all know, right, how the TB is classified as drug sensitive or drug resistant, or it could be pulmonary or extrapulmonary, and again microbiologically confirmed or clinically diagnosed case. Now there are various methods of TB diagnosis, right? We have microscopy, we have gene expert, we have expert XDR, we have TrueNAT. Just to tell about some pros and cons. So microscopy is the commonest one used for diagnosis as well as follow-up. Gene expert, which is now now we are using the ultra assays, which is a cartridge-based assays and can simultaneously identify TB as well as drug-resistant tuberculosis. Then we have the expert XDR, which is now considered to be a follow-on to the MTB. And then we have which also detects the fluoroquinolone, the second line injectable, and ethanamide. Then you have TrueNAT, which is similar to the gene expert. And then you have line probe assays, which are based on reverse hybridization, and interpretation is based on the development of the wild type and mutant type bands. Then we have the solid cultures and the liquid cultures. Now with the solid cultures, nowadays they are, because of the longer turnaround time, they phase out mostly. What we have is currently the liquid based cultures, and also the phenotypic drug sensitivity, which can be performed both first and second line, as well as the additional agents. So these are new automated tools which are coming in the microscopy. Some definitions have changed, like MDR, pre-XDR, and XDR. So MDR is like, when resistance to INH and rifampicin. When we are talking about pre-XDR, in addition to INH and rifampicin, to any of the fluoroquinolones, so that becomes a pre-XDR. Whereas XDR is in addition to your INH and rifampicin and to any of the fluoroquinolones, at least one of the additional group A agents, which is presently either bedaquiline or linezolid out to the board. So generally we use this regimen, right? So so there are various regimens based on the kind of resistance. So for INH monoresistance, you have a levofloxacin based regimen, whereas you have a shorter regimen for MDR, and you have a longer regimen for the XDR. So there are various regimens which are available, and there are certain pros and cons, and my other colleagues will definitely discuss on this. So what do we have? So we have direct methods and we have indirect methods. So as I have already mentioned about them, just to emphasize something about one of few of them, like we have like Malidov based. Apart from your gene expert, then there's also the whole genome sequencing. Indirect methods are there, which will look at the humoral immune response, especially the IGRA assays, the tubercle and the ADAs, whereas the serological tests are banned currently. Now, in reality, you have genotypic and phenotypic test, but what happens in real life is actually we use an integrated approach where we use both genotypic as well as phenotypic approaches. And when we say drug resistance testing, it essentially refers to genotypic methods, where when we are talking about drug susceptibility, they essentially refer to the phenotypic methods, and they can be used to assess response to treatment. So as I said, in reality, we use both drug sensitive as well as drug resistance methods. So there are various pros and cons of each and every method. So for the microscopy, easiest, fastest one, but we cannot differentiate between dead or live TB bacilli. We cannot species it. We cannot do a speciation out of this. And in case of possible bacillary, the smear, it can be a bit difficult. Then there are various automated tools that have come. Now coming to the phenotypic cultures, especially the rapid MGID based cultures. Now this is the gold standard, and they remain the most definitive and can be used to identify both MTB as well as non-tuberculous mycobacteria, and they complement all the molecular assays. They are useful for phenotypic drug sensitivity for both first line as well as second line, and we can they're ideally in case of extrapulmonary tuberculosis, and we always recommend culture along with all the molecular assays. Now the culture on an average they take 4 to 14 days, and susceptibility they will take 10 to 14 days. Obviously, they require rigid quality control and stringent adherence to the infrastructure and to the competency of the people who are performing it. So culture, now once you go to the review in the culture, then you should use the appropriate identification methods. People may use MPD64 or they may go for line probe assays. And what we are doing currently is we are also using Malidov. So it's a very, very good technology, and most importantly, it is important to use the correct terminologies, whether MTB or MOT. Now, this is the Malidov-based identification which you are using, which is over and above what the program is currently recommending for NTEP, but it gives a very good species level identification. It is based on the mass to charge ratio, and it is highly accurate, but at the same time, it requires a very high expertise, and initial setup cost is high for the instrument. Now, automated liquid cultures, it will take 1 to 2 days, and it will take similar amount of time for performing this, the phenotypic sensitivity. First line DSC is okay, but second line can be complex. The results can, be a bit difficult, but still it remains a gold standard. And as I said, the lab where you're performing it requires a good quality assurance program, proficiency testing, accreditation has to be there. So then, what is the need for the molecular test? Now, obviously, for a fast and accurate identification of the pathogens, for treatment initiation and disease control, and advancement in the molecular methods for MTB detection, so as to reduce the turnaround time from weeks to days, and also look at various genes which are there. Now the challenges, there are also challenges with those tests are like they may be expensive, experience is required. molecular methods cannot be used for the follow-up, and finding mutation does not always imply drug resistance. Now, PCR-based assays, they're available, which distinguish between MTB and MOT. They generally target the IS611 sequence, and they have good sensitivity and specificity. So then they have good turnaround time of 6 hours, applicable for pulmonary as well as extrapulmonary. Then you have the line probe assays now, which are based on the principle of PCR followed by the hybridization. Good for good in case of smear positive, but may not be that great when it comes to smear negatives and extrapulmonary. But then what can be done is you can apply culture and then combine the culture with the line probe assay, so then it can be good. Then 2012 onwards we started using GeneXpert. So very good methodology where we can identify MTB and rifampicin within 2 hours based on the semi-nested real-time PCR. What happened in 2017 is, there's a modification of GeneXpert came, which was named as GeneXpert Ultra, where it reduced the turnaround time and improves the sensitivity of detection from 131 colony-forming units to 16 colony-forming units. Is basically became more sensitive. Now with sensitivity, there were challenges with the trace and false positivity. But then as I said previously, there's a need for improved INS resistance because it is one of the key drivers of multi-drug resistant tuberculosis. So now, how to overcome this? Well, I'll just explain this with the example of a case. So there's a 45-year-old male who was suspected of renal tuberculosis. They were sent for GeneXpert Ultra. GeneXpert Ultra was showing MTB detected and rifampicin resistance was not detected. One may feel that initial impression that it is a case of drug-sensitive tuberculosis, but it turned out that there was a low-level INH resistance was detected, and fluoroquinolone resistance was not detected, indicating that it was it was not a pre-XDR case basis the fluoroquinolone resistance. Advantage being we got to know the results on the same day, right? So this came into being where it gives with these are the various target regions for INH, ethionamide, fluoroquinolone, and amikacin, kanamycin, capreomycin. The various genes were targeted. It has got very good correlation with respect to phenotypic DST as well as with sequencing. So yeah, I mean, this is a very good technology that you can utilize pending the culture results, pending the whole genome sequencing results, and can decide on to INH monoresistance or MDR, or for that matter pre-XDR, where you can use the bedaquiline based regimen on day one itself. So that is the power of using an expert XDR, where you can decide on to use of especially in case of drug resistant tuberculosis, whether to go for the bedaquiline based assays or not to go for bedaquiline based assays. Now, as I said, that's got a I've already discussed this, and can detect high as well as low level of INH and fluoroquinolone resistance, and can identify individual versus cross resistance as well. So it can be used as a reflex test for all the patients who are MTB positive, especially on a GeneXpert or a TB-DNA PCR, and as I said, can be utilized in case of MDR, INH monoresistance, pre-XDR to initiate their therapy, or bedaquiline-based therapy. So there are various papers on this and how this is useful. This was a paper in 2021. It spoke about its high performance and is a valuable tool, especially for the expanded DST and to initiate the therapy. So similarly, there was another paper in 2023 which spoke about how expert XDR helps to rule out fluoroquinolone resistance and initiate a bedaquiline-based regimen, and it reduces the diagnostic challenges and dependencies from high complex tests such as line probe assays and culture-based DSTs. So there is another paper which speaks about how it helps to reduce the turnaround time, especially in the resource limited situation where the setup for the line probe assays or the whole genome sequencing or the parasequencing may not be available, especially in cases of smear negative, how it also increases the sensitivity. So yeah, there are certain limitations and drawbacks to this. So then this brings us to the newer techniques, which is DNA sequencing methods. Like so based on these sequencing principle like Sanger sequencing, pyro sequencing, next generation sequencing, in this we have whole genome and targeted sequencing. So basically NGS it's highly accurate, and it's a single test where we can obtain the information for MDR, XDR, tuberculosis, and can also perform the strain lineages and can be used for molecular surveillance. And nowadays with the targeted NGS, it becomes quick and easy to implement. Now the advantage being that it gives the turnaround time in less than 7 days, so you can actually identify drug resistance genotypes for up to 18 different anti-TB agents. These are the various technologies, NGS based technologies. One can be performed from the culture or from the direct specimen. However, when you're going to perform from direct patient specimen, then there's some limitations to it, where we have to utilize actually some molecular baits to purify the TB DNA in order to get a good quality results, right? Obviously then you also have these sequencing targeted sequencing based assays, where you can selectively amplify targeted genes for DST and to overcome the other challenges of whole genome sequencing with a culture based to reduce the turnaround time. Yeah, so basically, just to summarize, tuberculosis has re-emerged as a top infectious disease, and it creates an urgent need for increasing awareness, and most importantly, upfront molecular testing. So as India contributes to nearly 26% of the global TB burden, so even NTP now prioritizes upfront molecular testing for TB diagnosis. With this, I'll thank you so much. I'll stop my presentation now. We can move ahead just to give a perspective of this.
Thank you so much, Dr. Patil. In fact, it was a comprehensive view on all the technologies available and their pros and cons. And this basically helps the clinicians in taking decision also as to which technology is more suited to their settings. What can they do about it? And Metropolis has, in fact, the breadth of diagnostic modalities available to them. And one thing I must comment is on your commitment, which is to fight TB. Thank you so much for this thing. And let me start with the panel question, and I'll actually be starting with you. Um, the
Okay.
question mostly which I had in mind for you was about all these diagnostic modalities. But if all these are available, still, what is that requirement of rapid and accurate? And you can actually, say by proxy molecular diagnostic test. What is the need? Maybe, summary of your whole talk can be given here.
Yes.
In,
So
we have been, I mean, we've seen the new drugs coming in, and the TB treatment paradigm itself is changing. So that is in the view of that.
Yeah, so thank you so much. So basically, I would like to summarize it in very simple words. One is that you have conventional methods and you have the newer methods. Now, conventional methods, and the newer methods, amongst them nowadays, the emphasis is on liquid culture based technologies. But pending the results of this liquid based cultures and phenotypic DSTs, you should have something which is going to reduce the turnaround time for the diagnosis and give initial I can say guide to therapy, so which could be in the form of your cartridge based assays, like for example Gene Expert or Expert XER, where on the day one itself within 2 hours you get to know whether TB is present or absent. And in addition to that, you also get to know if you perform an Expert XER about the INH mono resistance, as well as presence. If in addition to that, if there is also fluoroquinolone resistance, then you also get to know, okay, whether this is a case of pre-XDR, then you can actually start the therapy based on the bedaquiline based regimens or the other regimens. So that is like a power that the clinicians have on the day one itself within the first 4 hours. So that is, I would say, is that I want to say. Yes, later on when you will get results of the phenotypic cultures and the phenotypic DSTs, you can obviously modify your therapy. But to begin with, instead of a blind thing, you can actually utilize such cartridge based or a DNA based technologies. Now You also have whole genome sequencing, but they take the turnaround time is like up to 7 days. So to overcome this, you have something, or for that matter, even pyro sequencing, you have something in between. So these are your cartesian assays which can really help you and empower the clinicians to start the patient on the therapy right on day one.
Yeah, and with the informed, basically it's an informed decision essentially.
Yes.
And of course, like you said, culture remains the gold standard, and the therapy can then be modified according to the results. Dr. Parul, if I can come to you, ma'am, Dr. Patil also spoke about INH monoresistance quite a lot. Um, Looking at that and looking at the increasing INH monoresistance, I think about 23,000 cases out of those 63,000 DRTB cases are for INH monoresistance. What is your opinion on reflex testing and getting the results the same day, and how does it actually modify your patient management, ma'am?
Yes, absolutely. It is very much essential, I would say, because INH resistance is now not a small entity. It is 23,000 patient, or I would say in terms of percentage, it is 11%. In some studies show it as 13%. So it is not a small proportion of patients. And when we talk of elimination, when we want to eliminate every disease, and not detecting INH resistance, maybe 1 month, 2 months, or 6 months is, I think, a crime. So this is a time when we are detecting rifampicin resistance, we are doing sensitivity for quinolone, we are doing for other second line drugs. Then why not to do for isoniazid? So because isoniazid resistance is important to detect, otherwise our patient will not be treated. So I strongly believe that yes, there is a system in the our NTP program also, that if rifampicin is sensitive, then also we test the patients for isoniazid resistance. But I think in private sector also and in practice also, we should definitely make it a habit that whenever patient is coming to us for the first time, not only rifampicin resistance but also the isoniazid resistance should be checked proactively, because it will improve our cure rates. Second thing, it will delay, means stop the delay in the diagnosis and treatment, of course. And third thing, patient also now wants to know, because patients are also wanting, patient want evidence based medicine. It's not that we only want, they also want evidence based practice. And they ask us, okay ma'am, what is the type of tuberculosis? So I think proactive isoniazid testing is the need of an hour. And not the numbers, but not the percentages, but ethically also it is correct to get the sensitivity pattern whenever the patient comes to us for the first time, to show us whether this is sensitive type of TB or resistant. So I personally and I strongly believe that INH resistance should be checked. And we may use LPA, we may use other culture methods, but it should be checked. And in fact, of course, in algorithm it is there, but it is there after we get the rifampicin sensitiveness. If my patient doesn't have rifampicin resistance and my patient has rifampicin sensitivity, then next automatically in the algorithm of the NTP diagnostic algorithm, it is there that all the samples will be subjected for INH testing also, which is done at some places, not done at some places, but somewhere the guidelines have understood, the NTP guidelines have also mentioned it, that INH resistance should be checked specifically when there is rifampicin sensitiveness. But I believe, as a clinician, I believe that why not to test both the things at one go, at the first sitting, and whenever the patient is coming to us for the first time, so that patient also can be, means we can also comment whether this TB is sensitive or resistant TB. Right?
Yes, ma'am. And with this reflex testing on the same day, your loss to follow up is lesser. And your point is very well taken,
Yes.
wherein the rifampicin sensitive case also needs to be reflexed, because finally INH resistance or not will alter your regimen any which way. So no, very good points made there. And this with this, I'll come to Dr. Halder here. Dr. Halder, we actually, want to. So I want to ask you here is, and see, INH we have spoken. I will come to fluoroquinolone resistance and that discussion as well. But before that, we've seen multiple diagnostic tests for TB in market. How is that you are ensuring that the test that you have written, that is the one which is being done, whatever you have prescribed? And further to that, a follow up is that, what can help you to ensure that the prescribed test by you is only the one which is being done on the patient and not something else?
Okay, Swati, it's an excellent question from your part. So what is important is that we have to be ensuring that the diagnostic test align with the prescribed technologies. So there should be regulatory compliance. The test must be validated, must be approved by national and international regulatory bodies such as the WHO or the NTEP. Accreditation and quality control is also another important thing. So the laboratories conducting the TB diagnostic tests should be accredited by the recognized agencies such as the NABL and maybe recognized by NTP also if they are doing it. Another important thing is about the training and standardized protocol which should be followed. So laboratory personnel should be trained to use the prescribed diagnostic technologies such as the gene expert, the TrueNat, the light probe assay as per the operating protocol. And also about the role of the system generated reports in compliance and in transparencies, which has to be seen. Automated report, they minimizes the human error and ensure that the results are recorded systematically following the standardized format that and the reference range. And it should be integrated with the national tuberculosis program is also, that is what is expected and what is regarding the result that we get, it should be according to the national tuberculosis program that it is running. That's also thing.
So, very well made point, sir. And in fact, you also mentioned the system generated report and how that can help in the transparency and also in compliance. Pardon my saying this, because sometimes we do see that you might have actually prescribed some technology, but some places the testing will happen on another technology and the report might be reported. So this will basically impact your practice also, and the sensitivity of the testing is important. If the test was approved in the guidelines or not, that is important. So very well pointed out on those, sir. I'll come to Dr. Santosh, sir. So Dr. Patil mentioned it.
Yes, ma'am.
Dr. Parul mentioned about cases which are there for INH, and sometimes in RIF sensitive we don't do it. There are sometimes missing or undiagnosed TB cases itself.
Correct.
Like what we were mentioning in the data, 28 lakh suspect cases, but 2.5 million only have been notified.
Hmm.
What is the bigger impact of these missing cases on community level and also on healthcare system, HCP level, healthcare practitioners levels?
Yeah, very important question, ma'am. For the today, 24th of March, only World TB Day. This is a very important question. Basically, misdiagnosed or undiagnosed cases cause significant challenge to both the healthcare as per in community level also. So these challenges can have profound implication on health outcome, healthcare delivery, and socio-economic condition also. So most important in healthcare system, all increased burden on healthcare system and infrastructure. Misdiagnosed or undiagnosed case often lead to repeated consultation, frequent hospital admission, and need for extensive diagnostic investigation which overload the existing infrastructure, and escalating healthcare cost, that is the increasing overall healthcare expenditure or both patients and healthcare system. That is very important. Another, delayed appropriate treatment. Another one very important is erosion of trust in healthcare provider, and very important, increased risk of medical legal aspect also. That is, misdiagnosed can lead to malpractice claim and legal dispute and damage to professional reputation. That is very important. we all are here. So that is the also very important issue. Another one, a lower productive of healthcare worker. The time and effort spent on managing preventable and complication reduced. The focus on new or correctly diagnosed case, as already discussed by Dr. Patil. And weak health information system, this is also very important. Basically, patient of diagnostic error and all the things, that is very important. Another very important challenge in community level, that is very important, stigma. Today I'm discuss also about stigma. So basically significant stigma in TB patient in community level. Many of study in the biomedical college, in the another one study of Maharashtra and one study Tamil Nadu, that is shown that 42 to 82% of tuberculosis patients face stigma of tuberculosis, or 50% TB patient face stigma in every level, even a social gathering, even in a marriage, on all the things. And fear of tubercular patient, basically fear of losing on work, relationship, or house or school due to tuberculosis, and make people less likely to get tested and treated, which exacerbate an already challenging and on prognosis. These are the very important issue on this level. Basically, what is the having in the health level? Delayed in diagnosis and treatment, mental health challenge, and barrier to access healthcare. That is very important. And social level, increased spread of TB due to untreated cases, very important. And handed public health services, this is a very important. And
So, you have gone on mute. Dr. Santosh.
Dr. Santosh, you are mute. Dr. Santosh, you are mute.
Okay. So I have seen in NCR area, I have visited a one or two house or Jopad Juggi house. So there is a 2 MDR patient on enrolled. So the Mukhia of house denied, in my house there is no any tubercular patient. Even this is the stigma, and this is the happening in our country. So this is the big challenge of our country, even in a developed country.
Right,
So
sir. And in fact, so you are right. One is a stigma for the TB patient, which sometimes might actually deter them to go for testing itself or presenting themselves. But then once they are there with complications, that is another level of difficulties and trouble on them. But I will actually also add on to that, and you have already alluded to that, is the chain of transmission. The problem with the one untreated or undiagnosed case in society is probably 1 to 15, 1 to 20 kind of transmission in their lifetime. And that is something which is important. One more thing is that DRTB case transmitting DRTB is a very serious concern. So that is something that I'll say, and then breaking the chain of transmission becomes important. So this is an important area that we need to look at. And Dr. Goel, if I can come to you, and taking the similar thought ahead, misdiagnosed cases we have spoken about, and sometimes happens so that the in India actually everyone can do the TB testing. Everyone can write TB test and also probably start. At least they can notify in the Nextshare portal. So and can start the patient on treatment. What is have you ever seen or maybe how often, I'll say, that you see the treatment failure which is due to inadequate diagnosis or misdiagnosis, and what can be done about it?
So, Dr. Swati, I am working in a hilly state of northern part of India. So here the accessibility for diagnosis of even for sputum testing is not available in some districts. I will say. So the treatment failure is basically mainly due to the negligence on the patient's himself or herself, or by the late presentation to the doctors. Here, patients usually come with a history typical of tuberculosis, and still they do not want to get treatment for tuberculosis. That's also I have seen in last few months. Another interesting aspect which I learned over here in this hilly state of Uttarakhand is that it has happened to me twice that patient को जब बताया कि कैंसर है तो they said हमें तो लग रहा था कि टीबी होगा अच्छा हुआ कैंसर निकला. That was the statement. That is because of the stigma of the tuberculosis which is there in the villages, because of the stigma which Dr. Santosh was talking about. So it is very common in this state that even after the availability of rampant sputum testing, I will say 20 to 30% of the patients who are coming to me at a referral center are not being given this option of even this basic sputum testing. So some are being given empirical ATT on the basis of radiology and even the CT scans and basic the EBUS testing, which is now considered a basic test in pulmonary, are not being given the option. So I think in some part of India still the diagnosis is lagging behind as far as drug sensitive TB is concerned. Now coming to the drug resistant TB, I think it is even more important in some settings in this part of state, because we have some Tibetan monasteries where the tuberculosis is very, very common, and there the MDR TB is also being commonly seen. So I had a patient a few days back, in fact 3 days back, I diagnosed a case of simple drug sensitive tuberculosis, which was being investigated on the lines of hematological or malignancy for last 2 weeks. So sometimes doctors think otherwise, that TB is not that common, but I will say TB is probably the most important disease currently prevalent in India, and anyone presenting with long-standing fever, the TB should be the first possibility which should be ruled out. Coming back to the point, if a patient has been diagnosed as sputum positive and expert is negative, we also see these kind of cases. So in pulmonary settings, non-tubercular mycobacteria, nocardia, these things should be thought of, and should do the expert XDR and culture testing, which are often not done. And if sometimes we see the reports of expert which shows MTB traces and rifampicin insensitive, indeterminate, then also the further testing should be done, and empirical ATT of 4 drugs HRZ should not be prescribed to these. I agree. I am also doing the same practice, which I am saying that should not be done. But ideally, expert XDR test should be done if we have any doubt of the diagnosis of drug sensitive or drug resistant tuberculosis.
Right, and look, thank you so much, Dr. Goel. And in fact, this is worrying to know about the patient mindset. But yeah, like Dr. Santosh was also mentioning, stigma definitely is there with this disease. And truthfully telling you, a few years ago, I was also thinking that this should not really be that prevalent before I joined Cepheid, and then I realized that no, actually, what kind of prevalence there is. And the point is right that I'm not actually sure why should an empirical treatment be done or be started any which way. When the diagnostic modalities are available, although it might be lacking in certain areas, and where ground level up efforts are required to bridge that gap. I'm hoping that NTEP also is doing something about that. Plus, private sector needs to also step up in this regard. I'll come back to Dr. Patil and very quickly ask him a pointed question here. Is that Dr. Patil, recently expert MTB XDR has been recommended in NTEG,
Yes.
in the guidelines, and it has been recommended by NTEG. What kind of efforts or implementation efforts that Metropolis is doing, and which can actually lead the way for others also to follow?
So honestly, you see, we believe in giving a comprehensive kind of diagnosis, and at the same time, it has to be relevant also, because what we are talking about is we are dealing with very complex scenarios, complex cases where treatment can be really difficult, and treatment is for a very long duration. So if you're able to help the clinicians, if you're able to help the patients in a way where they know, okay, right at day one, this is what I'm having, and the results are pretty much going to correlate with the results which are going to come after 4 to 6 weeks. So that is their second thing is, when we're talking about you know drug sensitive tuberculosis, yes, things are very pretty much clear, but to know how do we go about this in case of drug resistant tuberculosis. So where we employ multiple methods, and most importantly what Metropolis is doing is as I'm saying, trying to offer a comprehensive solution, where we are not only looking at some basic tests like smear, or for that matter a culture, but we are also looking at the gene expert, the expert XER, the line probes, the phenotypic DST, whole genome sequencing, so that whatever limitations are there of one test can be taken care of the other test. WHO also recommends that it is always preferable to do a molecular test along with the culture based test. So that is in principle what we do is we offer a combo of tests at much cheaper rate and quality diagnostics. So this is our way of contributing to accurate diagnosis. And not only that, Metropolis as such is also participating in the NICSHA notification to ensure all the patients who are registered with us, they are notified to the government agencies, they come under the treatment umbrella, and they are further followed up. We also are providing something going beyond from as a part of our CSR activities, where we have adopted 1,000 patients of tuberculosis, where we give them the nutritional support through the local TB ward offices of municipal corporations. So that is how we are looking at the comprehensive diagnosis and support, not only the patients but also to the national TB elimination program.
So, and this must be the part of Nikshay Mitra initiative that
Yes,
was
yes,
there.
these are part of Nikshay Mitra initiative. Yes.
Yeah, and with the call of TB elimination by Prime Minister, I think 2 years, since 2 years,
Yes.
yes, and very, very noble initiative. So thanks, and no, we will take it in the consensus as to how, what kind of, how it actually helps in getting that whole comprehensive bouquet of testing, rather than just having one test and then basing your decision on that. Dr. Parul, if I can come to you, question to you is, while the NTP has recommended, while WHO recommends the upfront molecular test, we do see smears happening quite a lot. Uh, the issue is that for smear to be positive, high load of bacilli is required. So, in case of the load not being there, the case could be missed. What is your view in terms of how critical it is to have upfront NAT test for active case finding? I'm talking specifically about
Yes,
active case finding here. Yeah.
yes, definitely. I would say, and I'm very sure about it, that now it is a time when we should definitely use upfront NAT test for not only resistant TB diagnosis but diagnosis of TB. See, in Western countries, the CBNet is used for basic diagnosis of tuberculosis since so many years. But that when we want to eliminate TB, we want to go in that direction. Then definitely, what is the key points are that please diagnose it fast and please treat it fast. So early diagnosis and early treatment. So for early diagnosis, we cannot wait that in 1 ml the bacilli should become 10,000 to be detected in smear. Do we want that? We want that even if my bacilli is 50 to 150 ml for 150 per ml, then also I want to diagnose my tuberculosis condition even in spite of the possibacillary condition. And especially tuberculosis cases in pediatrics, tuberculosis cases in HIV, other immunocompromised condition, we have to use CBNet. So what I feel, what I have observed out of these clinical uh, days, so many years, that CBNet or any type of CBNet PCR based method is always having more sensitivity. Evidences are also to prove it, that CBNet has almost 95 to 97% sensitivity in sputum, and it has very high specificity, almost 99 to 100% specificity in sputum. Whereas in extrapulmonary TB tissues, CBNAT may have less sensitivity. For example, maybe ranging from 40 to 55 to 60%. But again, doing it for pulmonary tuberculosis, doing it for sputum AFBs, it is very, very important to use CBNet upfront instead of using smear for those patients. And we need to decide that once we do this in private sector also, then only we are going to achieve the target, because government gets only 30 to 40% of the entire patients, maybe 50%, not more than that. So in private sector also, if we make it a rule that whatever patients are going to a private and we have to diagnose them with more sensitivity, then we should definitely offer them CBNet at the first point itself. And also we have to explain the patient that CBNet has also one more advantage, that it will tell you whether the patient is rifampicin resistant or not. So it is good that we should use CBNet upfront for the test, and especially in private practice when the patient is a retreatment case, patient has failed, patient is a default case, then there is no question of sputum AFB by Zn staining, because 10,000, and we cannot wait that the patient should get 10,000 bacilli per ml in his sputum, then only we will diagnose. We have to see that even if patient has 50 bacilli per ml, we have to diagnose. And moreover, we should do bronchoalveolar lavage and bronchoalveolar lavage CBNet for early diagnosis. Don't wait that the patient's sputum will be expectorated. We can also diagnose a patient even if the sputum CBNet is negative. We can take BAL, and we can take BAL CBNet, and that also can give us early diagnosis for tuberculosis. So definitely there is no comparison between CBNet and sputum AFB, and there is no question, because it is a PCR based method. It is going to be highly sensitivity, highly specific. Only thing is that sometimes it can happen that the dead bacilli or genetic aspects are discovered when the patient is a retreatment case. In such cases, definitely we should go for the culture of the patient, because that time it may happen that it can give false positivity. But then in such cases, some retreatment cases or TB infertility cases, it is better to give culture to the patient, culture to the specimen. Otherwise, CB90 is definitely a gold standard, and we should definitely do it.
Yes, ma'am. And any which way, when if a case is coming for retreatment or relapse case, patient history will be important in terms of that. And if the patient is coming after having some treatment there and dead bacilli are there, it is a molecular test which will pick up which you need to have a consideration and have a thorough patient history taken before
Yeah.
before starting the patient on treatment. This
Yes,
is
just one more thing, that for one more thing, just retreatment
yes,
cases along with CBNet, please send for culture also. I think
exactly.
that midget culture or bacterial whatever culture you want to send, because there you don't want one or two drug sensitivity. You want to many drug sensitivity. So whether means if you send this for the retreatment and default cases, if you send liquid culture and AFB for first line as well as second line drug testing, then it will be really very useful, because patient will not give you specimen twice. He will give you one time only you can take some biopsy from the back, or from biopsy from the bone, biopsy from the cervical lymph node. They don't give you biopsy again and again. So retreatment cases, if you're sending gene expert, please send for biopsy and culture for AFB, and demand for first line and second line sensitivity also, because then the specimen is gone, and then again we are in problem that yes, now it is sensitive to CBNet is negative, then what to do? Then biopsy will tell you that what is the actual situation. Means culture will tell you what is the actual situation.
Yeah, so culture any which way remains, an adjunct to every treatment, every diagnostic modality. Dr. Patil in the beginning itself was mentioning that as well, that after all the with every molecular testing that is done. I'll ask the online audience for a little bit more patience. There are good questions there, about three more, and I'll request you to please stay on while I bring in Dr. Indranil and ask him that, if he sees referred cases which have got deteriorated, uh, what does he see as the reason for that, and what will be his advice to the practicing physician who have first interface to the patients. And we have been discussing about misdiagnosis and those cases getting deteriorated. I want to ask Dr. Indranil, how often does he see these kind of patients?
So thank you, Swati. So I am practicing in a place where it is a tertiary care. So I see a lot of referral. In fact, and this patient presents with extensive lung injury, some with respiratory failure and disseminated tuberculosis. Another thing I'm telling you, it is very difficult to get an ICU where isolation and tuberculosis patient can be kept. That's another important issue which we need to discuss. Now we should have some ICUs for tuberculosis or infectious disease in some periphery hospital also. So one of the reason is delayed diagnosis. So delayed diagnosis, missed or late diagnosis, often due to non-specific symptom, again because of, as told, limited diagnostic access or reliance on some outdated test. Inappropriate treatment is another important. Improper drug regime. They are not following the guidelines. They are inadequate dose. So I have seen 75 kg person getting the similar dose as that of a 35 kg. Inadequate premature treatment discontinuation. So the patient doesn't come for follow-up and the patient stops the drug themselves, or the treating physician may be stopping the drug because the patient complains that I cannot take the drug, there is some side effect with the drug. So this may be leading to disease progression. So drug resistance mismanagement or multi-drug resistance or extensive drug resistance due to inadequate drug supplement testing or poor adherence to that also. Another important issue which I need to highlight is the comorbidity, which is also to be stressed and to be managed appropriately. So diabetes, HIV, chronic lung disease, COPD with tuberculosis is a hell of a job, I'm telling you. Malnutrition and the other say comorbidities that may be given. Biggest concern in TB management is the diagnostic delay and inaccuracy. So it is increasing transmission risk to the community, disease progression leading to complications like cavitation, fibrosis, disseminated, and ultimately higher mortality and mortality rate. And this so more in the immunocompromised patients. So there we see again what my previous speaker has been telling continuously, that we are still relying on smear microscopy. Molecular test access is not there. Inconsistent sample collection result to false negative. That's also a sputum has been given. They are telling to give sputum and they give this sputum. The inside thick mucoid sputum is not being fetched. And again, lot of universal access or the lack of universal access to WHO recommended diagnostic test, gene expert tonight. So with this, my advice to the physicians would be maintaining a high clinical suspicion. Use the programmatic endorsed diagnostic tool. Prioritize the molecular diagnostic testing. It may be the gene expert or the TrueNat over conventional smears, and ensure access to drug susceptibility testing. That is the culture, as my previous speaker told, for detecting resistance early. Don't use empirical treatment without the diagnosis. There is a hope that empirical treatment based on the clinical picture, just a radiological opacity. Initiating tuberculosis treatment without the microbiological confirmation can be minimized to prevent unnecessary drug exposure, and again creating of MDR TB. So as my previous speaker told, bronchoscopy. So now bronchoscopy is done in many of the places. So if the patient cannot fetch a sputum, why don't rely on a bronchoscopy? And it is not that very invasive. And okay, so from referral to higher centers, patient with suspected drug resistance, HIV, co-infection, severe disease should be referred to specialized center. So that's all what in nutshell I can tell.
No, and thank you so much, Dr. Halder. In this, I'll add is the the physicians who are having the first interface do not trivialize this disease perhaps, and do not think that it is like what we were having in discussion, that um, if you think there is I think Dr. Goel was mentioning it, for long standing fever, cough and all, just suspect TB and then test for that. I'll come to Dr. Goel and then to Dr. Santosh. Dr. Goel, actually, there are so many variables when you are looking at the case, when you are treating them. It's just not the diagnostic test on gene expert, but also you will have to look at what kind of comorbidities, what age, and what kind of ECG findings, etc. and all. What is what are the comprehensive diagnostic criteria that you think should be fulfilled before you are starting the treatment?
So, Dr. Swati, I think we are talking beyond the diagnosis confirmation of Mycobacterium tuberculosis. So, first is that the drug sensitivity is there or not. That is the most important question. I think that was the context of this lecture. Obviously, after that, we have to get basic investigations, blood picture of CBC, RFT, LFT, fasting blood sugar, and HIV. These tests are basic tests, but often these tests are also missed before starting antitubercular therapy, because we see many times patients landing up with renal failure, or with more so with with hepatitis, and sometimes patient present with thrombocytopenia, anemias. So the basic investigation should be done before starting antitubercular therapy, so that we have a baseline picture that whatever is happening beyond this level. So I try to do these investigation, CBC, RFT, LFT, HIV, fasting sugar in all patients who are being started on antituberculous therapy. Apart from the ECG, which you mentioned, because of the new drugs which have come upon. So all these patients should be regularly followed up, and LFT monitoring is very important in some parts of India. There was a paper in which they found that in particular states, ATT-induced hepatitis were more common as compared to in northern part of India, was more common in the southern part, because of some genetic reasons. So what we do is that whenever the patient is coming up for follow-up, we usually do LFT more so in patients who have a baseline deranged LFT, and more so and also in patients who were previously alcoholic, had some abnormal liver function at any given time. So LFT monitoring is probably the most important monitoring which I follow in patients on EDT.
Well, thank you, Dr. Goel. And this question was more to emphasize for the audience which are listening to you. There sometimes we do see that cases, if the test is positive or negative basis that, or sometimes on the clinical suspicion only, ATT will get started, and then those cases will become the deteriorated one which we were talking about earlier. So this is where it is important to have a comprehensive view of the patient, not only the molecular test, but also everything else, multiple variables that Dr. Goel spoke about. I'll come to the very important question of fluoroquinolone resistance to Dr. Santosh.
Yeah.
What the question is, sir, 11,000 cases around that many, for fluoroquinolone resistance, and also the
Yes.
thing is, fluoroquinolone is one medicine which is otherwise also used for multiple other, ailments, and
Correct.
that is there. So, what is your view on that, and how does it impact your BPAL-M regimen?
Correct, ma'am. You are right. Basically, quinolone used by all the physicians, surgeon, orthopedic surgeon, and general physician. We are evaluated 1,000 patients those used by quinolones. So what is happened? The patient, they are started RHE and levofloxacin, and we are evaluated many of the patients drug sensitive TB. So many of physicians of our country used RH levo के साथ पेशेंट जल्दी सही हो जाएगा इसलिए लिख दिया, मरीज को बताएगा the patient are develop pre-XDR TB. This is happening in all the country, even UP, Bihar, Uttarakhand, even Gujarat, everywhere. So my humble submission, all the surgeon, orthopedic surgeon, physician, general physician, not to be used quinolones whenever very necessary. Even typhoid, malaria, all the things they are used quinolones. So please not to be used quinolones in the pneumonia and other things whenever not necessary. Second, ma'am, your important question is BPAL-M regimen. So what is the basics of BPAL regimen? That is very important. The basically BPAL study done in our country. So total 9 or 10 sites in our country, principal investigator by Priya Priyadarshini, and one of the my site, I am a chief investigator of that study, 2 sites of Uttar Pradesh, 2 sites of Gujarat, 2 sites of Mumbai, and one is NIRT Delhi. So we are used only, what is the medicine? That is the Bidaculin, Petomanid, and Linezolid. So the overall cure rate, if discuss about the cure rate, every site wise, my site, the cure rate in Agra cure rate is that is 90.6%. KGMC Lucknow, the cure rate is 88.6%. In Gujarat, both sides, the cure rate is 86.88%. And another site of Gujarat, cure rate is 92%. And the Mumbai site is cure rate 89.88%. And NIRT Delhi and Rajan Babu TB Hospital cure rate is 91.6%. So overall cure rate of this regimen, that is 92%. If any patient resistant with quinolone, so we are thinking about a few studies are showing 17%, 18%, 24%, 26%. A recent study published in my department, that is the 26%. Few studies shown that is the 32% resistance of quinolone. So I think there is no very BPAL-M is a very good. So this is the additional drug of moxifloxacin to add in BPAL regimen. So I think this is the wonderful regimen, only the 6-month regimen. Compliance, I think that this is the very good of this regimen. I have seen the patient of pre-XDR के साथ 2 साल से इलाज खा रहे थे. Now the pre-XDR treatment only 6 months. Patient is very happy. Compliance is better and everything is better. I think that this is very good regimen from my side.
So I'll take. I mean, so this was the last question, but we'll just sort of summarize this. What Dr. Santosh was saying is that BPAL-M regimen is better in terms of the total time, and also what I have had a discussion with some other clinicians in this World TB Day kind of discussions. They say that bedaquiline efficacy is improved if moxifloxacin is added. Resistance development is lesser. So therefore, BPAL-M regimen is better. BPAL definitely is non-inferior to BPAL-M, but then we should it. So the point to be made is that it is not that quinolones can be used left, right, and center.
Yeah,
we need to
definitely.
look at them from the perspective of preserving them.
Moxifloxacin definitely to be used in BPAL-M regimen. So that is the additive effect. So I think this is cure rate of the many of the study. Moxifloxacin resistant only 6 or 7%. Few study in MDR patient, in XDR patients. So I think this is the superior regimen, or in the view as an expert, as a clinician, and my view, this is the best regimen of our country for pre-XDR and MDR patients.
So we need to save it.
Yeah.
Just giving a minute's consensus on the whole discussion. Definitely, it is important that we have a quick diagnostics, which takes care of the patient, reduces loss to follow up. We have been always saying that culture remains the gold standard. So it's not that you shouldn't be sending the sample for culture. That is a requisite all the time. Stigma, we will have to all work towards that, to reduce it. But adoption of newer technologies perhaps will help us in terms of getting towards the goal of if not eliminating TB by 2025, which was a discussion, but at least shortening the gap of missing cases and putting all the cases on treatment. that will itself actually ensure that we are eliminating it. It will be a feat in itself. So over to you, Simran, with this, and thank you so much. Thank you so much, everyone, for your time.
Thank you so much, Dr. Swati, for excellently moderating this session. And it was a pleasure to listen to this insightful discussion. And thank you so much to all the panelists for taking up time out of a busy schedule and sharing your valuable expertise and insights with us on this important day, World Tuberculosis Day. Thank you so much to be part of this, for being a part of this discussion. It's an honor to have
Thanks a
you all.
lot. And apologies for 15 minutes over a time, but thank you so much for staying back.
Thank you.
Seeing
Thank you.
Okay. Thank you, ma'am. Thank you all. Thank you very much.
Thank you.